Hello, classmates and future counselors. My interest population is justice-involved clients. I've been studying criminology since my educational studies began, and I've also worked in some residential settings, some different types of stabilization care, and some actually reentry programs, as well as working with prisoners inside of a correctional facility. What I usually noticed over these experiences and through my studies is that behaviors that can be diagnosed as PTSD symptoms are often read very differently in correctional settings. So, if we look at things like irritability or hypervigilance and aggression, they are diagnostic features of post-traumatic stress disorder, but they also can often lead to some type of discipline in that correctional setting. Some people may be given longer sentences if they act out in one of those ways. There might be denials for early release. There might even be a possibility of getting put in solitary confinement depending on the intensity of how they are presenting. So, something from the textbook that I sort of feel like is worth mentioning is that Preston in the 2025 edition describes post-traumatic stress disorder as a increased sense of arousal and lists hypervigilance and startle response and self-destructive behavior as some of the symptoms. Well, if we think about a correctional setting, every single one of those is possibly going to get documented as a disciplinary problem instead of the symptom that it actually is. Um, I will mention that it doesn't mean somebody cannot be dangerous and traumatized at the same time. So the diagnosis can be present, however, the behavior is still something that would need addressed appropriately. So please hear me when I say I'm giving context around PTSD and how it may influence these people. I'm not using that as a justification for some of the actions that they may have done. Um, I guess the biggest thing that concerns me is that the behavior itself can be read one way upon sentencing or upon judicial review, but then it often doesn't get revisited. So, for instance, Fovit and colleagues in 2023 found that incarcerated men in their sample in France had roughly 5 times the rate of post-traumatic stress disorder in the community. So, the setting where that misreading is happening is also where that disorder is concentrated because of the density of PTSD diagnoses. Collins and colleagues in 2017 explained that correctional formularities can restrict medications, and that can be to manage cost and to limit what gets diverted or misused. Sometimes benzodiazepines might end up on that list, which my initial inclination would mean that that limits access to care. But then looking at Preston, that 2025 textbook does show that prolonged benzodiazepine use in post-traumatic stress disorder is actually associated with poorer outcomes. Collins and colleagues also have similar observations, but from that security angle. So they noticed that benzodiazepines are useful for acute agitation, but have found that they were generally not helpful long term. So it is one of the classes of medications that's harder to access in those settings, but it is also cautioned against. Um, there are some other constraints around medication. So in the Preston and colleagues book 2025, prazosin is listed for nightmares, and then alpha 2 agonists are listed as recommendations for hyperarousal. Neither of those are controlled substances, and they do say that the medications should target particular symptoms as they arise. That does take careful individual assessment, though, and Fovit and colleagues found that a lot of the times through individualized assessment, three different types of comorbid conditions can show up, and then it can make it more challenging to give the proper medication, while access to treatment segments, like the time in between them, is generally further apart if one is in a correctional setting. Collins and colleagues in 2017 described a specific sort of pressure in those facilities because sometimes correctional staff will consult with the mental health providers directly and ask them to do something about a disruptive inmate. So, I mean, that does assume that mental illness is behind the behavior, but those authors caution clinicians against overdiagnosing and prescribing because that could be an unnecessary response. Um, Preston and colleagues in that 2025 text do explain why that pattern can be a problem in trauma work. They mention how overly aggressive medication can be experienced by patients and clients as an assault rather than a right. So being controlled by a powerful other could be seen as a removal of autonomy. And I think that's important because Preston and colleagues also identified the common element across most presentations of post-traumatic stress disorder is that the person is experiencing helplessness, right? So medicating somebody into being compliant would then repeat that injury that the diagnosis is based upon. Some other research from Santiago and colleagues in 2025 found that more than 60% of incarcerated people are people of color. So, Black and Hispanic men are 6 and 2.7 more times likely to be incarcerated than white men. And the population where this misreading concentrates is not random. Um, so while I'm not a prescriber, the ACA standard 8.4.b does ask counselors to stay aware of their own values and to seek training when they risk imposing them. So I believe reading behavior as a character rather than a symptom would be one of those risks. If I were in that experience, if I were that provider, I'd want to compare my observations with somebody whose population has open medication access just to see if they have similar ideas or if they've noticed similar types of pressure.